All right, so we left off last lecture talking about how we use the medical model to diagnose and meet criteria for diagnosing individuals who are presenting with certain symptoms of psychological or mental health disorders, right? So today we're going to talk just about a couple of those. And if you remember in my last lecture, we said that there are about 20 categories in the DSM altogether. And out of that, we've got about 250 individual specific diagnoses. And that's a lot. And we're not going to be able to cover all of them today, but I'm just going to kind of give you a handful of ones that you're probably most commonly going to see in the field if you're going into psychology or social work or education or something like that. So we're just going to cover a couple of those today. So within those categories, we talked about anxiety disorders and mood disorders and personality disorders, right? And they all subclassify, they all have subclassifications of specific disorders. And one of the ones we're going to talk about today is anxiety. Anxiety is brought about for many, many reasons. And it could be, we talked about classical conditioning. Maybe somebody has a fear response that they were classically conditioned to. Say, like if you remember, little Albert was exposed to white rabbits. And then anytime that white rabbit was present, the researcher would start banging loud cymbals together and crashing noises, right? And frightening that child. So that child became exposed to a fear response based on a neutral stimulus, which was the white rabbit. Now, anytime he saw a white rabbit, he became fearful of that. Now, that wasn't really ethically sound back in the day. Of course, they didn't really worry about too much about long-term effects of harming people. You know, this is back in early 1900s. So the expectation was that this was more geared towards research and seeing how humans responded to such things without considering the long-term effects. So ethically, it was not a sound experiment by any means. I don't think that they've ever really gotten a hold of little Albert recently to see if there are any long-term impacts, but certainly we would be concerned about that today, conducting those kinds of research. So anyway, what we experienced, what little Albert may have experienced in that situation was an activation of a sympathetic nervous system to an external stimulus, right? Which was the crashing and paired with the white rabbit. That produced a fear response. And that happens more commonly than you probably would like to admit. We become trained to responding to certain things in that way if we've got some kind of fear or something. And that leads to many things. That could be generalized anxiety disorder. That could be specific phobias. That could even wind up in a diagnosis of, or meeting the diagnostic criteria of PTSD, which I'll talk about here shortly. So let me share my screen with you so I can just kind of give you a snapshot of what we look at with anxiety disorders, because it does really fall into several classifications when we're considering them. Okay. Now, if you remember, within the DSM, we have to meet a certain type of criteria, a certain number of criteria in order to actually say somebody is diagnosed with something, one thing or another. Is my screen blank right now, or is there something up on it?
It's black now. There was something up on it, and then it just now it's back.
There we go. Okay. All right. Thank you. All right, so within anxiety disorders, now this one looks specifically in children and adolescents. Of course, they're very similar within the timeline of adults as well. But these are just some of the specific ones we might see in children and adolescents. So separation anxiety disorder, as you can see, we've got a couple of them here that fall under anxiety. And this is not an all exhaustive list. In fact, I think there are probably around 30 specific specific anxiety disorders within this. So you have separation anxiety disorder, you have specific phobia, you have social anxiety, generalized anxiety, and anxiety disorder, NOS. Okay, so this is like a more focused subcategory for anxiety disorders. And of course, they've got specific ones within each one of them. But so this just kind of gives you a general sense of what we see with anxiety disorders. So for example, separation anxiety, we have to meet, I think, 4 or more of these criteria according to the DSM. And of course, it doesn't tell you that, but we're going to look at some of the features that somebody might be presenting, right? In this case, a child. So developmentally inappropriate or excessive anxiety regarding separation from home or parent. Now, inappropriate. If you remember last lecture, we talked about the 3Ds of diagnosing, right? We want to look at distress, we want to look at dysfunction, and we want to look at deviancy. This one really speaks to deviancy. Is this a strange behavior compared to a child of that age? And if we can answer yes to that, like we have a classroom of 30 students, maybe kindergarten or first grade students is usually where we see separation anxiety start to form. And a vast majority of them are okay with the teacher, and one of them is not. Just in excessive crying, like pining and longing for mom to come back, and for hours and hours maybe, or even up to an hour or two. That could be a sign of developmentally inappropriate excessive anxiety, okay? Characterized by inconsolable or persistent crying. We talked about that. Children may be aggressive or self-injurious. That might look like somebody banging their head, a child banging their head on the floor, or smacking themselves or something just to kind of get attention, right? Anxiety and avoidance may occur in relation to this. Okay. So on and so forth. Nightmares about being separated, like every day during school, for example, that night, the child is waking up with night terrors. That would be an indication of separation anxiety. Now, we want to leave a little bit of wiggle room here because we don't want to jump the gun, especially when it comes to diagnosing children, but really anybody in general. We have what we call kind of like a criteria timeline here, as you can see off to the right. So we give a little bit of wiggle room for people that might have short-term symptoms or short-term features of these disorders. Okay, so if a child, for example, is taken to kindergarten and shows signs of anxiety, kind of like meets every one of these to a diagnostic criteria, we're not going to be really jumping the gun to diagnose that child. Okay, we're going to probably wait to see if there are things that they can do, if it wanes, if it starts to reduce in intensity and frequency over the span of a month. We can kind of just say this was just like an adjustment period and not really worry at treating for separation anxiety or any other kind of anxiety, because it's going away, it's reducing something. It was just like an adjustment period. So that's kind of what this is for. Specific phobias, as we talked about, things that injure us, things that might, or we have a fear of injuring us. Like, for example, how many of you are afraid of spiders? Or how many of you are afraid of heights or even snakes, right? These are really actually common fears that we have, and these are specific phobias. And again, we're going to look at the 3Ds for diagnosis. Are they deviant, right? Is it abnormal to be afraid of heights? Probably not. Is it distressing? It could be, right? Is it dysfunctional? Some people fly regardless of whether they have a specific phobia to heights or something like that, right? So looking at that is really important. Let me give you an example of somebody I served in the Air Force with, and they had a severe fear of heights, flying specifically. This person would not get on a plane, and how they got through their Air Force career without ever flying was just, it was really interesting. I never thought about it, but this person never flew anywhere. They only got stationed in the United States. Anytime they had an office job, and anytime they had to transfer somewhere, they drove. They never flew the entire time in the Air Force, which I thought was really impressive. Being in the Air Force, it's like being in the Navy and being afraid of water or something, right? So this person, it wasn't realized that this person had a dysfunction with that until they got a job outside of the Air Force in a company. And for a while, this person was doing really great in their field. They were going to meetings and they were selling the product. And it really didn't come to pass until they were required to travel some distances, right? And for a while, this person was driving those long distances and avoiding flights, sometimes 15 hours just to get to a location and coming back that same week, driving back 15 hours that same week. And then they started getting a little bit bigger of a region that they're responsible for. And, after, I think at one point, this person was driving about 20 to 22 hours each way to attend these meetings and meet with the clients. But beyond that, it was a little bit more unreasonable for this person to drive those distances. So when their boss came to them and said, you need to fly to this location, and this person said, no way, I'm not doing it. No way, no how. I'm not getting on a plane, never been on a plane. And they said, you will fly or you will get there or you will be terminated. So at this point, the person had to undergo some pretty rapid therapy to figure out what the heck was going on and what they can do about it. And luckily, they were able to work with their employer to overcome that after a couple of weeks. And it got to the point where this person was able to fly and practice stress reduction techniques while they were doing it in guided imagery. So it was a successful treatment, but that sort of thing happens, and that kind of really drives home my point of what dysfunction is, because that person's quality of life started to diminish because they were unable really unable to fly because of that specific phobia. So leads to avoidance, right? Now, phobias are a pretty normal thing. They happen, right? We all get frightened by something, and we have that unconditioned stimulus and that neutral stimulus paired up. Can we break that? If we can, within 4 months' time, it's really not an issue. Okay, so as long as it can be overcome over a reasonable amount of time, where the intensity of that anxiety and the frequency is reduced to almost 4 months, then really we just call that, again, like an adjustment period. Social anxiety. Okay. Now, this is really a tough one to really diagnose, because, again, I think we talked about social evaluative threats, where we all feel like we're being evaluated, we're being judged by a crowd. We all want to fit in. We thrive in numbers, and we know that. And when we get in front of people and start talking, we start to worry about what they think about us, right? Are we saying the right things? Are we articulating? Are we fumbling our words? How do we sound? How does our voice sound? How do I look? Am I sweaty? Is my face getting red? All these things go through our head. And for some people, it becomes so unbearable that they won't get in front of people. Okay. I'm going to speak to this one because this is something that I struggled with as a teenager. I was successfully able to avoid all public speaking things throughout high school, public speaking assignments and tasks. And it was to the point where I was able to call off pretty much every class that I had to get in front of the class and speak. And it didn't come to pass until about my final year of high school, when I had a teacher that just would not let go. He insisted that I get up in front of the class and teach. Or I'm sorry, not teach, but give my, it was Shakespeare's To Be or Not to Be. Had to recite it, knew it frontwards and backwards, but just couldn't get in front of the class to speak it. So long story short, I passed out almost twice in front of the class. It was that nerve-wracking, and it really caused me to rethink whether or not I wanted to go to college, because I didn't want to do anything with public speaking. So long story short is I kind of went through my own therapeutic process and exposed myself to bigger and greater audiences, and until the point that I'm even here in front of you today, being able to speak. So it is something curable. Now, could I have been diagnosed? Probably, because it went beyond that 4-month period, right? But it was something that I was able to overcome, and it has not really negatively impacted my life or my quality of life. All right, so general anxiety disorder. This is where somebody might experience, for example, panic attacks or severe symptoms of anxiety to the point where they can't function, but there's no reason why. It's just they're constantly anxious about something, and that maybe they're nervous, their heart is racing, all the signs that we see with anxiety, but it's a little harder to determine. Maybe they have test anxiety, maybe they have anxiety about their grades, but it's stuff that is not really a rational phobia of any type, right? um, they look at occurrence of two or more situations, okay, where that happens, like for example test anxiety and get in front of public groups to speak or something. So this would be kind of like social anxiety and test anxiety or something like that mixed into one. We could call that general. We could probably broaden that and call it general anxiety. Excessive anxiety and worry for most days. Again, really not able to put your finger on exactly what that trigger is. And at least one physical symptom must be present. And they kind of list them here: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep difficulties. This is really a majority of what I see with anxiety disorders. For example, people that might come to me and say, it's coming to in my practice, it's coming up on the end of the semester and I haven't slept for a week. And I might ask some questions like, well, what do you have going on? Probably very normal stuff. They've got 6 final papers due and 3 final exams and an essay or something like that. They just have a lot of stuff piled on them to the point where they're not sleeping at night. And we might look at that and say, okay, well, these are normal things. This is a normal amount of stress. However, we're looking at this as you're not sleeping. This could have some negative impacts on you. And we'll try and figure out ways to tweak some things, maybe with sleep hygiene, or in some cases, if it's that severe, maybe even medication or something like that. Those I would again consider an adjustment disorder, like it's just something very brief. Something's happening. Once that threat or that issue is over, that situation is over, we go back to normal. So we look at general anxiety as having occurred more than 6 months. If it's been going on for 6 months or more, then we start looking at diagnosing this. Now, anxiety disorder, NOS, means not otherwise specified. All right, so this is kind of like a general catch-all. Maybe they have one or more symptoms. They have just a couple of occurrences. We don't know why, but it doesn't really fit specific phobia, doesn't follow social anxiety, doesn't follow generalized anxiety or separation anxiety. Okay, so this is just kind of like a catch-all for, we don't know what it is, but it's something. Okay, so that's anxiety. And I know I said that I was going to kind of talk about how we're going to mix both of these treatment modalities in with this. Now, one of my favorite ways to treat anxiety disorders is through mindfulness, what we call mindfulness, and or combined with cognitive behavioral therapy. So what that means is that with cognitive behavioral therapy, which we call CBT, what we're doing is we're rearranging our thought process. We're kind of reframing things. And when we experience triggers to anxiety, like for example, if somebody had anxiety over a test, probably some of the best ways to do that is, first of all, reframe our mind to think of it a little bit differently. Is the test really that big of a threat? Like, for example, driver's license. I get so many people that are afraid of that talk about anxiety with driver's license. How many of you have taken your driver's exam and failed because you were nervous, right? That's a normal thing. We all do that. I think I failed twice, okay? But helping people to reframe that, because you have 3 tries on, for example, you have 3 tries on a driver's license exam, or the driving portion of it. So helping people to understand that, yeah, it's normal to have that anxiety, and maybe you just need to get that anxiety out for the first one, or practice under actual test conditions with maybe their parent or a friend or family member sitting in the passenger seat with the checkboard criticizing what they're doing, right? That would be exposure. That's kind of like exposing them to that threat so that they can get used to that test environment. Okay, so those are just some tricks that I use. And mindfulness, of course, according to your book, is just connecting the mind-body experience. letting your mind know that everything's okay. And we can do that through breathing techniques and what have you. So that's really a big part of that. And that's something I teach with all my patients or clients as well, is relaxation techniques, so that when they are exposed to something similar to what it is that triggers them, is that it's okay to just start breathing and get your body back to normal. Okay. So any questions on anxiety? Now any questions, first of all? Anybody have anything to add? Okay. Before we move on, I do want to talk about panic disorder, because panic disorder does fall under anxiety. And what panic disorder, what it entails, is a sudden intense panic, both physically and emotionally. Okay. So somebody might have this fear, and it just builds and builds and builds until it feels like they're having a heart attack. They're having a hard time breathing. They're they're hypersensitive to lights and sound around them. It feels like their world is crushing in on them, is what's been described. So having a panic attack is pretty normal if you're encountering some really fearful thing. Now, if it happens frequently, we would call that panic disorder. Okay. So, and again, exposure therapy and cognitive behavioral therapy are both very, I'm going to use the word efficacious, which means effective in treating that. Okay. All right. So let's look at, let's see, what do we want next? Oops. Oh, we got a lot of things going on here. I apologize. Actually, I think I'm going to probably just get rid of these slides. Sorry, I thought I had these slides pretty well marked, but I don't. All right, so let's kind of move on to our next category here. Let's see, which one do I want to pick? All right, so let's talk about dissociative disorders. We talked about that on, don't like red is angry. So dissociative disorders, probably I'm going to say the coolest in the field. And I mean that in a lovingly way. I mean that from a research or a professional's perspective, because there are a lot of things we don't know about dissociative disorders. Okay. First of all, we know how they happen. We know what the progression is like, and it's usually associated with some kind of trauma in most cases, right? But dissociative disorders are really what we consider a break in conscious awareness. I'm just going to put awareness. Awareness, not just awareness, but memory and identity even. Now, many of you have probably heard of the word, identity, multiple personality, right? Identity. What is multiple personality? Has anybody, I'm sure you've heard of that. Anybody care to share what multiple personality looks like, either from your reading or from watching a movie or whatever?
Isn't it basically like the switching between different alters or personalities?
Yeah, dissociative. Yeah, multiple personalities, just like we described here, is switching between different personalities, switching almost like between different operating systems on your computer, right? You might have a Windows machine that you can run Linux, or for those computer geeks out there like myself. I know multiple personality is the term that we're most familiar with, but it's called dissociative identity disorder. Okay. So disorder. So many of you that are going to be working in the field, This is called DID. So don't forget that, because if you go in there saying multiple personality, you might get looked at a little. It used to be called multiple personality, but we've with DSM-4 and 5, we call it the dissociative identity disorder. So dissociative identity disorder is really a memory loss, almost a memory loss, where somebody is switching minds almost to the point where they're forgetting like different portions of it. Now, I will say that I've had multiple people that claim to have dissociative identity disorder, and they came in and they tried to talk to me, but I don't think I've ever actually had. I could probably count about 24 cases, maybe a little bit more, that I've had where people were claiming to have this. I've never actually seen a true case of this. I've never actually diagnosed it, because most people, I'm very trained in picking up on certain inconsistencies in their stories and bleed overs of their roles and their personalities. And when I detect that, of course, it takes a lot of work and a lot of skill to really detect this in somebody and diagnose it effectively. So it is very, very rare. I'm not going to say that it doesn't happen. There's a lot of skepticism as to how this occurs and how people could fake this. And I think maybe some people do. Now, I will say the way to treat this is not to debunk. Any of you that are going into the field, either social work or counseling or therapy, is not to challenge that individual. Because if you think about it, they're coming to you for a reason. And if they think that they have dissociative identity disorder, there's a reason for that. And the quickest way to get them out the door and away from you and not ever come to see you again is to challenge their belief that they have that disorder. So treatment, which is, I kind of abbreviated here because I'm used to doing notes this way. Treatment is TX, okay? So the treatment modality is first validating, okay? Validation, it's huge. Making them feel comfortable, like they want to come and talk to you. And then if for whatever reason, like if this is one of those rare cases where it's a true case of dissociative identity disorder, or even not, we would use a psychodynamic approach. Now, psychodynamic, if you remember back in Freud, right? Looking at the id, ego.
My apologies.
Sorry. I don't know why Siri broke in there. Not again. The id, ego, and superego, right? The subconscious. For some reason, they're tapping into their subconscious or accessing their subconscious. So we want to know why. Why is this occurring, either on purpose or is it actually a rare case of DID? Okay, so that's like the big, the kind of like the grand poobah of dissociative disorders is DID. And of course, throughout there, you have dissociative amnesia, which is memory loss for specific situations. Like somebody might do something and then like commit a crime, for example, and then claim that they can't remember, like dissociative fugue, like going on an entire drive or completing an entire event and then coming back home and not having no memory of doing that whatsoever. That would be dissociative fugue or dissociative amnesia. Okay, so that's really all I want to cover with dissociative disorders. Okay, with mood. Hopefully, I think I have enough time to talk about mood here. So mood disorders. Next category that we'll talk about, mood disorders. Now, mood disorders show up in how we express how we really, express our feelings. Okay. So feelings and emotions are something that we have on the inside. Our mood is how we behave towards those feelings or emotions, if that makes sense. So the operative word here is mood. How are we displaying ourselves, our feelings and our emotions and our thoughts? And we can kind of break that down into different moods. We can say somebody might be irritable, or somebody might be withdrawn, or somebody might be nervous, or whatever we can observe on somebody, we can say is mood. And we're going to talk about, so affect, which is an emotional reaction to something, okay? So for example, maybe reaction, maybe you over the Christmas times, you know, especially with many of us not being around family, maybe like an AT&T commercial comes up that you're watching, and it shows a family flying all over the world to get together into one location and having a nice big dinner and unwrapping gifts, and that gets you thinking about how much you miss your family. Now affect is how we show that emotional reaction. Okay, so we start maybe crying a little bit or tearing up, or maybe just kind of feeling a little, you know, but our affect is really how we react to that moment. Okay. Disorders of mood. So disorders of mood would be disturbances in emotions ranging from mild to moderate, and can be maybe even extreme in some cases. So for example, let's talk about that. Go back to that AT&T commercial that's showing that family together. Somebody sees that, and it should, you know, normally cause somebody to feel a little sad, maybe a little warm-hearted. But if somebody starts laughing maniacally at that, that might be a disturbance of mood. If somebody's at a funeral and starts hitting things, or, you know, that might be a little bit more appropriate if somebody's showing anger during a funeral. But if they start laughing, that might be a problem. That's a disturbance of mood, right? So anyway, disturbance of mood is what mood would normally happen in those situations, and what is the person displaying. If it's something completely different, we can say that there's a disturbance of mood. One of the biggest disturbances of mood that we can talk about today is called major depressive disorder. Major depressive disorder, or MDD, otherwise known as depression, moderate depression, severe depression, depression with mixed emotions, or trying to think of some other specific diagnosis for that. Yeah, with mixed emotion, mixed affect, or panic. You know, there are plenty of subclassifications for that. But major depressive disorder is marked by feelings of blue, feeling blue, isolated, loss of interest, irritability, sleep loss or too much sleep change, put plus or minus. But anyway, you know, the list goes on and on as far as these are just probably some of the most common symptoms that you might see with major depressive disorder. Now, the problem with major depressive disorder is the person's desire to withdraw from social events, withdraw from friends and family, which can be really hard to detect unless the person is aware that they are kind of not regressing, but falling back and ignoring pleas for help or something like that. So what really this major depressive disorder can lead to is what we call suicidal ideation. Actually, I'm going to do a different slide for that. So suicidal ideation is thoughts of suicide, pretty much what that means. And thoughts of suicide that can lead to gestures or actions. Now, a little bit something about suicidal ideation. It happens. It happens more frequently than we would care to believe. Okay, I can say that a majority of the people that come to me and talk about their depressed state or even anxiety or bipolar even might reach to the point of suicidal ideation, is it happens very, very, very frequently. And people are afraid to really bring that out of themselves. Why do you think that is? Why do you think people are scared to admit that they might have thoughts of suicide, or even may have even had gestures of it in the past?
They don't want to be judged.
Right. Exactly. They don't want to be, because we kind of think about, we hear about it all the time, people getting institutionalized, getting hospitalized because of suicide, right? Or somebody intervening or something like that. People, again, going back to that social evaluative threat, people don't want to be judged for that very reason. So maybe they think that they can handle it, or maybe they're just embarrassed about it. But for whatever reason, suicidal ideation is very, very tough because a lot of people have it. And I like to normalize it. I'm saying this very delicately because it is a very normal thing. And I let people know up front if they're struggling with bipolar disorder or depression or anxiety, letting them know that this is a very normal thought to have, because when we feel like we're hopeless and we feel like we don't have anything left to do, we don't have any avenues to explore to solve our problems because we want to solve them. If we don't have any options to do that, our mind goes to avoiding and escaping, right? And when it gets to that point, it can show up in different ways. Some people might actually think about death. Oops, I almost put birth. Some people might think about death. Some might think about avoidance, right? Just fantasizing about not existing anymore. Or actually, I'm going to put not existing, because this kind of exists on both realms. Not existing. And some people might even think about running away. Now, that doesn't sound like suicidal ideation, does it? But it is, right? Because it's coming up with the same suggestion, the same strategy is if I am not here, that pain cannot exist, right? And there's a flaw with that thinking, because we fantasize about not having that pain to the point where we start thinking about death or avoidance or running away. But the fallacy with that is death could lead to, obviously the person's not going to feel the pain anymore, but it's going to lead to pain of other people, which some people don't tend to realize. If they were to complete that, they might, if they ran away, what would that do to their family as well, right? Their problems would still be there at the home. But anyway, so helping people to rationalize, first of all, normalizing this as part of that treatment therapy, is normalizing it and making somebody feel like this happened because you feel like you have no other way. Okay, so normalization is part of it. Okay, the other part is to assess lethality. What do I mean by lethality? I'm talking about the risk of actual death, either accidental or on purpose. Okay, so lethality can exist on several different continuums. We can see it in just vague thoughts. Okay, so what do I mean by vague thoughts? Somebody coming to me saying, I have an extreme amount of stress on my plate, and I just think about what it would be like for me to not be here anymore. So very existential. So the two things I'm going to ask are, have you ever done anything about it, or are you planning on doing anything about it? And if they say no, we can kind of just say lethality is pretty low. Now, that doesn't mean that I'm not taking them seriously. It just means that we are really evaluating them to say that I don't have any worries that they're going to walk out the door and do something in the next couple hours or couple days or whatever until I see them next. But what I do is develop a plan, which is part 2 of this. Develop a safety plan. So if things become if things become too overwhelming, they know to either talk to somebody, call a crisis number, or get to a hospital as soon as possible, so that we don't evolve to like the next step of planning or acting. Okay. because once we start planning, now we've kind of upped our game, right? So what would it look like? And again, if I say, the person comes to me and says, I have thoughts of suicide, and you say, okay, so do you have a plan or have you ever acted on this? They'll say, well, I had thought about it, and if I were to do it, it would be by hanging or pills or something like that. And then I would ask a little bit further questions. Have you ever done anything like that? Are you planning, like, do you have a time frame, or do you have like a trigger that's going to cause you to act on something like that? And if they say no, I can probably work with that. I may suggest that they go to the hospital, just because at this point, we don't know. There are a lot of tools out there a therapist has to kind of gauge the lethality of suicidal ideation. And then, of course, if anybody comes in and says, yes, I have a plan, and as soon as I walk out that door, I'm going to complete this action. Now we have a safety emergency, at which, we're probably going to stop talking about what's going on and start asking them to make a plan to get to the hospital and following up on that. Usually for me, I ask them if they would be willing to go by ambulance or have somebody that we can have accountable, like a parent or somebody, drive them there. So that way that we can ensure their safety. Okay. But anyway, so just to kind of wrap this up with everything, is helping, being aware, what we would consider to be the worst case scenario in mental health or psychology is the completion of suicide. That's ultimately what we want to avoid. Of course, we want people to get better, but number one, above everything, it's like our number one objective in psychology is to do no harm and prevent somebody else from doing harm. And we do that by looking at whether they could harm somebody else or they can harm themselves, and figuring out a way to come up with that safety plan and come up with a strategy to keep them safe and those around them safe, even if that means getting them to the hospital so they can get the best care. So anyway, I know I'm kind of running out of time here, but I just wanted to end on that note as far as suicidal ideation. One final thought on that: if for whatever reason you have those thoughts, or somebody that is entertaining those thoughts, please be aware. It's again more normal than you think, and there's a lot of people out there that can provide help, and it doesn't always necessarily mean having to go to the hospital because somebody's actually planning on doing it. If they're vague thoughts, that's very treatable in an outpatient setting. So just something for you to keep in mind. Okay. Any questions or any thoughts or comments on the lecture today?
No.
Okay. All right. Well, if nothing else, that's all I have for today. Hopefully I'll see, I think I got quite a few of you on the list. I'm going to be sending out that schedule shortly for the presentation next week. So have a great weekend, and we'll see quite a few of you next week, either as an observer or as a presenter. All right. Have a good weekend.
Thank
You
you.
too.
Yep.
You too.